Hi, I'm Susan, this is Hayley, and welcome back to Cancer Research Demystified. This episode is all about surgery. Well, for these thousands of years, surgeons have been improving the way they do things. So, for one thing, back in the day, really cancer was considered absolutely a death sentence. So the surgeries themselves were really aggressive, and they took a lot of healthy tissue as well as the tumour. Over these decades and centuries, they've been figuring out that you can take less and less healthy tissue in some cases, not in others. And this has been a huge field of research, trying to figure out exactly how much extra tissue you can take.
Especially if you're looking here, right, it's in an organ. If you take all of that organ away, you can have a lot of problems. You want to preserve as much normal functioning as you can.
Right, and that's probably the main thing, I think it's safe to say, that has been going on in research around surgery for those last thousands of years. But then recently, in recent decades, there's been some more exciting things going on too.
Okay, so new advances. One thing is they're trying to shrink the tumours before they actually do the surgery. So they'll use other treatments to do this, like chemo, radiotargeted therapy.
Right. We can also use these other treatments after surgery to mop up any little remaining tumour cells that are floating around.
Yeah. Instead of the traditional knife method, they're using energy beams to try and destroy the tissue while it's still inside your body.
Right, and they're even advancing with engineering the actual instruments that they're using. And there's constant advances in this. We even now use robots for surgery.
Hello.
This is Joe Norris. So, what do you do?
So, I am a surgeon. I'm a registrar in urological surgery, which means surgery of the urinary tract, which is the kidneys, the ureters, the bladder and the prostate, also in the men, the testicles. I'm also a researcher and a scientist, and I'm a student as well, so I'm currently doing a PhD here at UCL.
That's how we know him.
Yeah.
So, Joe, we've already told our viewers about some of the kind of areas that we're researching, people like you are researching around surgery. One of the things we've mentioned is robotic surgery. So why are people starting to involve robots in surgery? Why is that a thing?
So, robots have been around for probably over 10 years now, so it's not a brand new thing, but it's a relatively new thing in the history of surgery. The reason that people are using robots, really it's an extension from laparoscopic surgery. So
so that means...
That's like keyhole surgery, right?
So yeah, laparoscopic surgery is keyhole surgery, and the robot is the next stage. So it uses the same sort of camera, but instead of the tools being connected to fixed straight rods, that's in laparoscopic surgery, in robotic surgery, it's mobile arms and mobile hands.
So instead of having to do things with chopsticks through a tiny hole, you've got a bit more dexterity.
Yeah.
Okay, so these aren't human-shaped robots walking up to the patients.
No, people get a bit confused about that.
Okay.
I read a piece in the New York Times recently that suggested it was like that, and that the robots are independent from the surgeon.
Oh wow!
That's not the case. So the robot is really just an extension of the surgeon. So the surgeon will be descrubbed and he'll be sat across the room on what we call a console, which is a bit like a video arcade machine.
We'll try and have a picture pop up for you guys here, maybe.
So he or she will sit down and put their head into a visor. And
wow, that's real computer game stuff.
And then that visor is connected to the camera, which is inside the patient. And the camera is stereo, so that it actually gives the surgeon a 3D view inside the abdomen, which is an advantage over laparoscopic surgery.
Yeah. But the surgeon's still in the room. We're not talking someone's doing surgery on me in London while the surgeon's off in, the Caribbean.
Didn't they try that?
Yeah, that did happen. Yeah, you can do that, yeah. Can do that, but normally they're in the same room.
Just in case something happens.
Exactly. Because if something goes wrong, you need to be able to take you to the next stage. You might need to open the patient and do open surgery.
Okay.
Yeah.
So what other kinds of research are going on around surgery then, other than robots?
Well, there's a lot of research going on in surgery. I think all aspects of medicine have research going on, but we surgeons really like to push the field further, especially in urology actually as well.
Okay.
So I think of all the surgical specialties, urology has been the one which has been pushing sort of technological advances. So you mentioned robotics.
Yeah.
Really, robotics started in urology. So the prostatectomy was the sort of the gold standard operation for robotics, and then everything else has fallen from there.
So prostatectomy is removal of the whole prostate, right?
That's right. It's the operation that we do normally for cancer of the prostate.
Okay. Alright, so I've heard of some other things that maybe people wouldn't think of as surgery. So focal therapy, can you tell us about that?
Yeah, so focal therapy is a type of, I guess you can call it a surgical procedure that we do. And it's tissue selective. So instead of removing the whole gland, the prostate in that case, you actually just destroy the part of the gland that has the cancer in.
Okay, common sense solution, but not as easy.
And the prostate has been late coming, so in the rest of the organs in the body, they all move to that much quicker. So instead of removing the whole breast, you remove the lump within the breast.
Okay, yeah.
Or you remove the whole kidney, you just take half the kidney off, which we call partial nephrectomy.
And with lungs, people just lose
Exactly.
lungs.
So the prostate is lagged behind, and the focal therapy that you talked about is, as I say, tissue selective therapy, where we, with an energy source, so that could be freezing, we call that cryotherapy, or you can do it with ultrasound, and we call that HIFU.
Or lasers.
And lasers, or light, or drugs, any of those sources is just to kill the part of the prostate that has the cancer in.
So you're selectively taking the surgically removing, but without your hands necessarily.
Exactly, tissue selective therapy, so that the remainder of the prostate, which has all the function that a man needs in terms of his erections, his ejaculations, his urinary continence.
Okay, so we've talked to you about some other clinical trials going on around our research before, but what are the clinical trials that are happening in surgery?
So there's lots of trials going on in surgery across the whole spectrum, but to keep it narrow to prostates, because that's my area of interest, and to keep it also specific on focal therapy and on robotics, there's two trials I'd like to mention. The first one is called Neurosafe, and that's led by a surgeon called Greg Shaw, who works at UCLH.
That's too.
Yeah, and so some of my colleagues are working on this trial, and the idea behind Neurosafe is to preserve the nerves that are around the prostate. So around the back of the prostate are the things that we call neurovascular bundles, which are essentially responsible for giving a man an erection, and that's the most important thing they do. And so when you remove the prostate, as in a radical prostatectomy, then most of the time you actually damage those nerves.
Oh wow, okay.
In such a way that most men will become impotent after the
Wow, completely. Well, I guess, yeah, if there's the nerves are required. Wow.
So
that's a big deal for men.
It's a huge...
And this was standard with a radical prostatectomy before.
Yeah, and so when you're consenting a man for a prostatectomy, you flag up that it's probably you're going to have your erection, lose your erections, basically. But the idea behind Neurosafe is to preserve these nerves.
Okay.
So say if the cancer within the prostate doesn't extend to those nerves, is not involving those nerves, then what they propose is that you can shave around them rather than through them.
Okay.
So remove the whole prostate, but not the bit around the nerves.
God, that must be very fiddly.
It is fiddly, but the key thing about Neurosafe is that the histology, or the way that we look at the cells, is done in the middle of the operation. So they take a sample, they take the prostate out, and then the histologist will look to see whether the cancer has extended beyond the
what, live while the patient's still sort of waiting
while the patient's
with the
still
robot.
asleep and the robot's still there, and so they're checking for what we call a positive margin, which is basically where the edge of the cut, if the cancer extends beyond the edge of the cut, then you've not cut enough.
Okay, and you just keep...
Yeah, so they're one of the key things about surgical oncology or surgery for cancer. You've got to cut the cancer out, but also you've got to cut a little bit into the healthy margins, because you've got to remove the whole cancer and not leave anything inside the patient.
Makes sense.
So what happens in Neurosafe is they take the whole prostate out, and then they check, the histologist will check to see that there's no cancer remaining around the area that they've spared, around the nerves.
Oh, that's great. Wow, I imagine a lot of people are involved with that.
And ultimately it's to see whether they can give more men their erections after a prostatectomy.
Wow. And then what? You said there was another clinical trial?
Yeah, so the other trial was PART, P-A-R-T, which is basically a randomised control trial started in Oxford by Professor Hamdy. And it's comparing robotic surgery against focal therapy. So that's the therapy I mentioned before, where part of the gland is destroyed, not the whole gland. So men are either have a radical prostatectomy, robotic, or the focal therapy, and it's to see whether the outcomes are different.
And the outcomes are cancer, I guess, but also things like the side effects of the treatment.
Yeah, oncological control is the most important thing, so controlling cancer, but then other things, as you said.
Yeah.
Okay.
Exciting stuff.
Right. So then, from those clinical trials, you guys will pull together all of the data and then be able to make recommendations to the rest of the world on how they can improve
that's
their
the idea.
surgery, and then more patients get these
Yeah.
better surgeries with worse or less side effects,
Yeah.
which will be pretty great for the world.
Exactly.
So, you know, thanks. And I think other than that, that's about all we were going to ask Joe. So
one word on these trials. These are obviously state-of-the-art trials that you would need to be consented and recruited for, and they are only happening in local centres. But if you are interested, there are various websites which we can link to, or talk to your clinical team and see if they can recommend you for anything suitable in your area.
okay, and with that, if you have any questions for Joe, we haven't asked him if he will answer them, but we'll make him. So just put them in the comments below. And other than that, we'll see you next time.